Thank you. I think we've heard a recurrent theme already today about how devastating these ACL injuries are. Dr. Quinn did an excellent job this morning of kind of summarizing it. So I'm going to just briefly talk about this for a few minutes, and then we're really going to get to the meat of how do we help prevent these injuries, which Dr. Myer is going to present. So I'm an orthopedic surgeon. I take care of teenagers, high school and college athletes with ACL tears on a daily basis. This is what I do all day, and I'm glad to be here to talk about it. These are my disclosures. All the studies that we'll present today are IRB or IRCOOK approved, and these are our funding sources. So ACL injuries, we've already heard today, these are very important. Close to 500,000 people tear their ACL every year, and for each one of them, it's a devastating injury. If we go in and we try to just sew the torn ACL back together, it doesn't heal. And so we don't do that anymore. What we do is we take out the torn ACL and we replace it with the graft of tendon. That's called an ACL reconstruction. And that's really our current gold standard of treatment today for athletes with these injuries. The epidemiology of this, as we've heard already today from Dr. Ackerman and others, in 1972, Title IX came through and we saw this exponential rise in women playing sports. And this was associated with other really great things. So increase in the number of women college graduates, an increase in the number of women with PhDs, but also an increase in ACL tears. Our best guesstimate now is that there are 400,000 of these tears in the U.S. alone each year. And there are multiple studies have now shown that young women are 2 to 6 times more likely to tear their ACL than male counterparts in the same sport. So how do we diagnose an ACL tear? Well, there are 3 main components to making this diagnosis. One is the history, one is the physical examination, and then sometimes we do an MRI as well. Key features of the history for an athlete who's down on the field, it's usually a non-contact injury. Most of the time they'll report either hearing or feeling a pop in their knee. They typically get early swelling, and they typically can't go back to play. So you know for most of these athletes, if they can't go back in and play, something is seriously going on. People with a partial ACL tear can play, so you have to be careful. If they felt a pop but feel like they can go back, you've got to be careful if they, because they could have a partial ACL tear, and then on the next play they can tear it. So you've really got to watch these athletes carefully. And patients who have torn a meniscus instead of their ACL typically won't get that immediate swelling, that early swelling in the first 12 hours. They'll wake up the next day and their knee will be swollen. Physical examination, we use basic things like range of motion, looking for an effusion, those kinds of things, or swelling in the knee. But we also have some specific tests for the ACL, and one is the Lockman test. And this is illustrated in the top picture there. That's a physician who's got one hand that's pulling the shin bone forward while it's stabilizing the femur or the thigh bone, and you're trying to feel any shuck between those 2 bones. Is it the same on both sides, or is it looser on one side than the other? That's a Lockman test. And that's a very sensitive test, but not totally specific, meaning that you can see that, you can get a positive test for that in most patients with an ACL tear, but it doesn't necessarily mean that anybody with this positive test has an ACL tear. The pivot shift test is another test that's very, very specific. So if you get a positive pivot shift test on a patient, you can feel pretty sure they have an ACL tear. But it's also very difficult to do on an unanesthetized patient. So only in the office you'll get it about 24% of the time in somebody who actually has an ACL tear. And that test is done by bending and straightening the knee while putting a little bit of gentle pressure and rotation through the knee and seeing if you can feel it shift. The initial treatment for athletes with an ACL tear, or for anybody with an ACL tear, is RICE, so rest, ice, compression, and elevation. And then we work early on active range of motion and quadriceps strengthening, as well as gait retraining. And really the post-injury phase really emphasizes regaining full extension of the knee. But it typically takes 4 to 6 weeks after their injury to get their swelling down and their motion back. And as surgeons, most surgeons now recommend that patients wait until they've got their full extension back and they've got their swelling out before they would go to surgery. So typically there's a 4 to 6 week period between when the athlete's injured and when they go to the OR for their reconstruction. So this is our current gold standard of care, ACL reconstruction. I picked these pictures because they were dramatic. When we actually do this surgery now, we typically can do it arthroscopically, so through much smaller incisions, but the degree of surgery is still the same. So the procedure is to take a graft of tendon from someplace. This is showing taking the middle third of the patellar tendon with some bone on each end, and you can use that as a graft to go through the knee. And then you drill tunnels through the shin bone and the thigh bone. You can pass the graft then through those tunnels and fix them in place with a variety of devices depending on which device you like the best. And that's basically what an ACL reconstruction is. It's replacing that torn tissue with a graft of tendon. Now, this operation is excellent at restoring basically gross stability to the knee, and patients feel much more stable after it. The indications for doing this operation, so when is it warranted? Well, we know from level 1 studies that ACL reconstruction works better than simply suturing the ACL back together. And ACL surgery is also known to significantly decrease the risk of getting a future meniscus tear. So if you've torn your ACL and you go back to cutting and pivoting type sports, if you don't have a reconstruction, you're at a much higher risk for tearing your meniscus than if you have your knee reconstructed. But ACL reconstruction isn't perfect. It hasn't been shown to lessen the chance of developing post-injury osteoarthritis. So what can patients expect if they have an ACL reconstruction in 2013? What can they expect after their 6-month rehab period? They can expect to have a normal range of motion. They can expect to recover greater than 90% of their strength. They can expect to have a little bit more looseness on the operative side than the other. Many patients won't notice this 1 to 2 millimeter difference. They can expect a relatively low rate of developing a postoperative infection, so less than 1%. But they also need to expect that there's a 3% chance they'll tear their ACL. Now that's for their other ACL, excuse me. So if they tore their right one, they go through rehab, chances of them tearing their left one is about 3% in the general population. However, if we look at the teenage athlete, the risk in those athletes is between 10 and 20% of them tearing their other ACL. In addition, once you've torn an ACL and had a graft placed, you're at a 3% risk of tearing the graft, if you go back to sports particularly. And in the active teen population, that risk is 10 to 20%. So it's a lot higher in these adolescent and college athletes. And in addition, you have a risk of developing osteoarthritis, which can be up to 48% at 6 to 10 years out from an ACL reconstruction. So good but not perfect. And again, where it's really not perfect is in these teenage athletes. So there's a high rate of early graft failure, as we said, up to 20% in the first 2 years. There's a higher rate of late graft failure. So at 10 years, for active athletes that have had an ACL reconstruction during their athletic phase, at 10 years their graft failure rates are about 50%. That's really high. These people are not taking it easy on their knees. And there's also a high risk of post-traumatic osteoarthritis. So in athletes who go back to their sport, there's actually a close to 80% chance of them developing osteoarthritis at their knee at only 14 years out from their ACL injury, whether or not they have our current best standard of treatment, or ACL reconstruction. This is particularly problematic in the adolescents because if we look at when people are tearing their ACLs, we can really see that the peak, especially in girls, is here. This is 15 to 19 years of age. So if they get injured here at this time point and they'd start developing osteoarthritis 14 years later, that's an awful long time somebody's going to be living with the sequelae of post-traumatic osteoarthritis. But help is coming, but it's not here yet. So in our lab, we're working on a technique to help regenerate the ACL after it tears. So rather than taking it out and replacing it with a grafted tendon, we want it to heal. And this is a study that we did in pigs, and these are pictures of a pig's knee at a year out from each type of surgery. So on the left panel, we cut the ACL, and then a year later, we went back to see how the joint was doing. And you can see there's no ACL here. But at the end of the thigh bone, the same place that people get it at 14 years, you see this big cartilage defect where it's not shiny. So normal cartilage looks more like this. You can see the cartilage is wearing away in this knee. If we do the gold standard of treatment, we do an ACL reconstruction here in the animal's knee, and then we let it walk around for a year, and then we look at it. We're seeing again that osteoarthritis is developing in that medial femoral condyle, or that part of the joint that people get it as well. We have a new technique now that we've worked out where we basically put a resorbable suture across the knee to stabilize it initially, but then we put a scaffold that has bioactive factors that stimulate healing of this ligament. And when we do that procedure and look at what happens a year later, you can see that the cartilage actually has been protected. We don't see the development of the osteoarthritis. So this is something that we're working on in the lab. We're working with the FDA to try to get approval to go to clinical trial, but we still have some hurdles we have to reach before we can get to clinical trial for this. So if you're interested in more information on that new technique that we're developing or other things about ACL injury and treatment, we just published a book with Springer. It just came out this spring. It's called the ACL Handbook, and I just refer you to that for more details. So what is the best answer for ACL injury? It's really prevention, and that's why I think what Greg's going to talk about is so important. He's going to talk about how we can help prevent these injuries in the first place, because I really, I've taught my 6-year-old girls soccer team how to do, the FIFA 11. I think these exercises are really important because every ACL injury we can prevent is a knee saved. So we'll hand it over to Greg.
Thank you. Thank you. Thank you very much. Well, I really must be making it now because I get to be up here with my idol, Dr. Murray, and so I'm honored to be here. Thank you, Dr. Ackerman, for inviting me to do this. But some of the stuff she is doing with the repair is going to change how we practice medicine. Stephen Hawking Discovery Channel is featuring her as one of the scientists that change how we're going to look at medicine over the next few years. So pretty cool stuff that she's doing. But I'm going to try to keep the kids from getting to her, and that's what we're going to talk about today is how can we do some of these prevention strategies. And I'm going to talk a lot about some of the how-to, but I think the when is one of the most important things we're going to talk about today when we need to implement these training programs. So this is some data by Julie Agel where she looked at the NCA rates, and basically what we did is looked at the rate, so anywhere from 3 to 10 times greater risk. The males are 0. Females, on average, are anywhere from 2 to 10 times greater risk for an ACL injury in soccer and basketball, the sports they looked at. Well, what I did is I ran a regression line on that data, and you look throughout the years. This is kind of when we started figuring out Title IX caught up with us. We started seeing there was a problem. We started doing these prevention programs. What is those regression lines telling us? The problem's getting worse. It's going the wrong direction. And this is some of Jen Hoopman's data. She reported that ACL injury rates at the NCAA level are going up 1.3% each year in female athletes. So we don't have the problem fixed, so where we got to go from here? So Dr. Quinn presented a lot of this earlier today, but what can the risk factors be? And we think if we're ever going to get at this, we got to figure out what the problem is. And they kind of group into 3 categories: anatomy, hormones, and neuromuscular. And this was the most obvious area to focus on initially, as females tend to have different anatomy, maybe a little bit wider hips, might put their femur at a different angle. And so a lot of people focused on the Q angle initially. Others, she reported this to the intercondylar knots. So females tend to have a more A-shaped notch, so a little bit smaller. So maybe they have a smaller risk. We reported that laxity, those girls with the loosey-goosey joints, who can take their thumb to their forearm? Can anybody do that? I figured you'd be able to. So those girls that had the really loose joints, the hyperextend their knees, we found that was predictive of or related to injury. But we also have seen that it's not related to our dynamic motions. There's been a lot of studies that have tried to look at anatomical factors, either related to our dynamic motions or injury risk. And see, this girl has a lot of valgus, standing valgus, but she doesn't necessarily go into valgus when she jumps and lands. So maybe it's not all about anatomy. So what about that other criteria, hormones? How does that relate to injury? Well, Dr. Quinn presented this data. What we did is we looked at the ovulation and looked at all the studies that were in the literature and looked at laxity. And this is when we found that females had the increased laxity. So hovering right around ovulation, looks like there's something going on. Well, if we looked at injury in a follow-up study, they all kind of clustered in this first half. So if you throw those 2 studies together, maybe there's something going on around ovulation right here. Maybe it's something increasing risk. So this is one of the first studies I did when I got out of graduate school, is we had to track female athletes. We're going to test all these female athletes, track their menstrual cycles. I really hated this study. For 2 months, I had to track them, bring them in, get blood draws. We did all this biomechanical testing. Has anyone read this groundbreaking study? What do you think we found? A whole lot of nothing. We did find in a small group, the girls on oral contraceptives tended to have a more stable neuromuscular profile, but we found no effects of the menstrual cycle on their dynamic performance in all of our tests that we did. So basically 2 years of my life. I got to meet a lot of girls, but not a lot of data. So what can we really do about the anatomy and hormones anyways? There's not a lot of options. We can put them on oral contraceptives if that's an option, but that's not what we're going to do for a lot of our young athletes. So this is where we like to focus our work, and we think where we should be spending most of our time. Look at this neuromuscular area and seeing what factors might be related to injury. And we focus on the knee. In Cincinnati, we really love the knee. And this is what a knee should do. It's a hinge joint. It's supposed to flex and extend. Not supposed to have these out-of-plane motions. You can see when you have these out-of-plane motion, here sits the ACL, it doesn't take much motion to put a lot of stress. It's disproportionately loading the ACL. So what we want to see is, can we predict, looking at their biomechanics, looking at these knee motions, can we predict who's going to go on to an ACL injury? So what we did, we tested a lot of female athletes, tested them with motion analysis, so I can show you the biomechanical. So they came in, do a 3D motion analysis test. We can calculate thousands of variables from this. We can predict all the joint torques and looking at the measures. Does anyone know this study, like what measure came out as predictive? It's that one factor was that load driving the knee into valgus, or that knock knee position, that load that pushes it into that position. That one variable was highly predictive of an athlete that was going to go into something like this. So this was actually a game changer as far as what we started to focus on. We really started looking at this mechanical we called knee abduction, but it's basically what's visually evidenced is that girl that lands in a knock knee position. So let's look and see if we can see this mechanism in some injuries and see if you guys can actually visually see if it happens. So you can see the athlete right here. Can you see if she has any valgus? I love going after lunch. Can you see the valgus? What about in volleyball? It's the server. Can you see it there?
Yeah, we get it.
Oh, I got a lot more. What about handball? Think it's chronic?
Like, how many thousands of times has she done that without tearing it? But
We'll
now
talk about
it's
that.
just cumulative.
I think she puts herself in that window of opportunity, and then the one time that goes a little overboard. Gladiator? What about wrestling? You think I can find a wrestling video? Can't see on the first one. Watch when they do the back view. Watch her knee pop in valgus. She tore ACL there. This is my best video. This is males. When he goes in deep valgus, you can see the ACL rupture. See it pop. So again, who thinks I spend too much time on YouTube? I'm not even going to let this problem just be out on athletics. I get in the underground, and I've even found that this problem with valgus happens in drunk American college students. So we see enough videos, you think valgus might be something we can talk about and look at? So let's move on. So this is a young athlete that we had come into our lab. What we do is longitudinal studies looking at puberty, and we're trying to figure out what happens during puberty to these young girls and what happens to them to when she looks like this. What happened to her in those 3 years of testing? Why does she jump like this? Does anyone see any difference in her mechanics? Yep, that's exactly it. So what happens to girls during puberty? They grow. This is data where we actually did Tanner staging on kids in Texas in the middle of summer. Don't ever go to Texas, Lubbock, Texas in the middle of summer. That's a bad idea. But what we did, this is vertical jump, each Tanner stage. Females, on average, do not jump any higher than they're ever going to jump right at puberty. So if an untrained female, if you don't train them, they're never going to have any more power. Males, each stage, they naturally adapt to increased demands. What do females do when they grow? Get longer levers. The two longest levers are torquing on that knee. What else happens? Hips widen a little bit. Center of mass gets higher, harder to control. So we keep playing at high-level sports, but we don't adapt. So maybe there are training programs that we need to artificially induce some of these neuromuscular spurts that we talked about in young females. So where should we focus our efforts? Well, Dr. Quinn talked about this a little bit. The hamstrings are our ACL's friend, and they can help flex that knee, which puts it in a safer position. But you can see some of the fibers of the hamstrings can help prevent that anterior translation of the knee. We also see that it crosses both sides of the knee. It can help prevent some of those out-of-plane rotations. So maybe we should look at the hamstrings and see how they affect it. So this is data looking at longitudinal data, young girls, females, each pubertal stage. This is their hamstring strength to their body weight. Does it increase? What do males do? Boom, boom, boom. Each stage goes up naturally. This is their valgus angle. What do females do as they go through puberty? That valgus continues to get worse as that knock knee position gets worse with each stage. What do males do? They go through that motor more on stage, don't they? They get gawky, but then that hamstring strain kicks up, they come back out of that valgus. So they adapt and come back out of it. But I think it's more than the hamstring. I think there's a bigger player, and I think it's the hip. Look at this girl. Look like her mechanics are driven by the hip. And the hip's an important player because that's the biggest muscle that controls some of the movements of the femur. So what's that data look like? This is longitudinal data on about 900 kids in our lab. We brought them in each successive year. Males, on average, increase their hip strength all the way each stage. Females, no change. This is inverse dynamics. So this is in the motion lab. We looked at the ratio of their quad loading to their glutes, so that posterior chain relative to their quads. Females, on average, in puberty, land with a quad strategy. So what that looks like in a biomechanical landing, it'd be very upright. They'd have a torso upright, and they'd have a straight leg position, which is also a dangerous position. Where males use overall hip strategy at pubertal, and at post-pubertal, it's even more of a hip strategy, so that ratio. And what that looks like is a more flexed trunk, and they're down deeper. They're firing that glutes, and that's what it looks like. So that's a mechanic that we want to look at that might be beneficial. It's basically driven at the hip. This is a young female in our lab. Do you think her trunk and hip control is affecting her lower extremity biomechanics? She about tears her ACL. So she has no control of her pelvis. So I think that's a pretty telling video that's maybe an area that we need to focus on, that hip, and that hip might be a critical modulator between our trunk and our lower extremity biomechanics. So what do you guys think the end of this story is for this young female? Yes. There she is tearing her ACL using those valgus mechanics. So again, she puts herself in that window of risk, and she keeps doing it. Eventually, she's going to get caught and bit. And there's her MRI. So what do you think happened to her during maturation? Well, this is her biomechanical data, some of her strength data. Quads stayed the same. She didn't have any degradation, but her hip strength, relative hamstring strength, and her ham-quad ratio all got worse as she went through puberty. That's not good. What do you think her valgus loading did? Each successive stage, until she went 2 weeks later, tore her ACL. So that valgus loading, that impulse, that knock-knee load was really what drove it, we think. What's really interesting is we just put this paper out is there's potentially a relationship between anterior knee pain. So younger girls have this same biomechanical risk factor, that knee loading, that was predictive of someone that was going to go on to anterior knee pain. But it happens when they're younger. So we think potentially that's a lower level threshold of risk. But what that could be is that maybe that young girl with anterior knee pain is telling you something. I got some mechanics that are going to put me at risk when I get bigger and taller and heavier. So maybe we need to think twice about their training before we send them back out to sport. This is longitudinal data of that valgus loading, that same measure we've been talking about. This is about 900 kids. And basically what we looked at here is when they go through, this is percent of adult stature, and this is about a 13-year-old girl. We think your risk is high after you cross 21.7 newton meters. Basically, females live above that. After 13 years old, on average, females tend to live above that threshold that we think is high risk. This is a completely different data set where I pulled national database and we looked at the knee injuries in kids, both males and females. Look how it's following almost the same pattern. Maybe this is a risk factor that's related to a lot of injuries in young kids. So the question is, and Martha alluded to it a little bit earlier, why do we care about preventing injuries in young kids? So how good does she play the next day? Girl tears her ACL. How's she perform the next day? Yeah, she's up to this 6 months to a year. She's going to be sitting on the sidelines. What are the intermediate effects? Anybody know who this is? Shay Ralph. Anyone know how many times she torn her ACL? Well, I was giving this lecture in Las Vegas last year, and I thought it was 5. Somebody raised their hand and said, I'm not supposed to tell you this, but I'm treating her for a 6 right now. So what we found is this, in the younger athletes, just like Dr. Murray talked about, if you look just at young athletes that return to sport, this data in our lab says 1 in 4 is going to come back to you. So athletes that have torn their ACL have a high risk of injury. This is some data out of Norway. Gretel Mikkelbus looked at whether you're at risk of OA. And what she did is extrapolated data out to 20 years. And basically what they reported is, regardless of whether you get your ACL repaired or not repaired, you have a 100% chance of OA in 20 years. So again, there's no good solution besides prevention. So these are 2 young girls in Cincinnati, twin sisters. Each went on active in volleyball and soccer. Both of them went on to have ACL injury in their high school years. Does that look like a good arthroscopic video, Dr. Murray? How's that knee look? This is 14 years later. They're both getting salvage knee procedures. And here's how they spent their 30th birthday. So do you think they got a long lifetime of bad knees at this point? So they're ready for some total knee replacements. So what we looked at, what do athletes like to do a lot of? They like to eat a lot. What do you think happens to them whenever you take away all their physical activity? So we had that same hypothesis. We looked at the girls that in the year that they had a knee injury, what happened to them relative to their peers. And on the females, on average, that had a knee injury, their body fat percent kicked up 2% relative to their peers. So again, we think that there's also detrimental effects to as far as obesity markers. So I've given you a lot of data. I'd like to explain this a little bit clearer way. Does anybody know who this is? No one knows who this is? Yeah, you can't answer. Does anyone recognize her? Who is it, Ruth? That's J-Lo. So when J-Lo was younger, I used to talk to her a lot, and I told her that you need to be in these training programs. And again, as young females mature, they're going to have some increases in body fat, but on average, someone like J-Lo is going to turn out all right. But when I talked to her, I said, you need to get involved in these integrative neuromuscular training programs we talked about. I said, you need to start when you're young. Get involved when you're in pre-adolescence. She blew me off, even with the dates. I don't know why she wouldn't go out with me. But then during adolescence, I said, you really need to get involved in these training programs. And my proposal to her is, I can make a better version if we get involved in these younger programs. But what do you think really happened? You know how the story turns out? What do you think happened, Ruth? She did. Story of my life. So J-Lo blows me off, and here she is at Video Music Awards, and watch her jumping mechanics. Crawls up here, that big valgus knees, goes on to an injury. So don't you think she should have listened to me? So what do you think the outcome of this story is? Yeah, she goes on to injury. We just saw the data. Increasing. She's bound for unhealthy. So the point of this is we want to get these kids involved and prevent something like this and keep them active in sports. So the question is, what about these 2 young girls, these twin sisters? When do you think I got the call from the coach? After all those girls had torn their ACL. So they're ready to run the coach out, and they go, oh, now we're interested in injury prevention, so that's when I get the call. So the whole point of this talk is we don't want to be missing this opportunity because it's critical to hit it before that happens. So what we're going to talk about is when should we start? And I think that's the most critical. I can give you exercises and protocols, but where I really want to take you home today is when should we start these training programs to actually prevent? Because what we often see is people have the problem or they have a rash of injuries. That's when they decide it's time for injury prevention. And we often wait till girls are at their peak rates and they say, oh, we'll do it when they're 16 years old. No, they've just played 3 to 5 years at high risk. So we're going to talk about a lot of this in the age span when we should do it. I've been talking to you about this INT, or this integrative neuromuscular training. And when you train younger kids, a key aspect of what we do is education and instruction. And I can tell you that most all females do not know that they land in valgus. When they do a jump landing, they don't even feel it. They don't know that they do it. So education and instruction is critical to helping them make the changes in biomechanics that you want to have. We also have to consider some differences in kids when you're training younger girls. And again, we're going to talk about training young. There's also often different ways they take feedback. You have to consider some of their psychosocial aspects. The kid has to be able to take instruction. But what I think is really important and what's often missed is young kids have to have a primal level of strength. And a lot of times we don't get these resistance training programs and get get girls involved in strength training programs at an early age, so they don't even have that basic level, basic building block of primal strength where they can build motor skills and safe fundamental movement skills. So that's a key aspect to think about, and when we should start getting these girls involved in resistance training when they're young. And you can see even the monkeys know that it's time to get exercising, to get strong. Pardon? I spent a lot of time on YouTube, and then Tosh.0 is my favorite show. So this is how a lot of people used to train kids. Is that a good idea, you think? Think that's going to prevent any injuries? That's going to last for about 10 minutes, if that. Smile, Timmy. This is fun. This is how kids normally use exercise equipment. So this is not what I'm proposing to you. What's my training error here? So what am I doing wrong? Yeah. Why does she have a bar on her back first? That's the easiest thing. She can't even sit down.
Why are you letting her keep doing that?
Exactly. Because I turned the video camera on. So that's why one of the things that the key aspects, it's not necessarily the exercise, it's actually stopping them and not letting them perfect this incorrect form. So that's a key aspect to what we do. You have to give that key feedback to stop this. But I can guarantee you walk through the weight rooms and have strength coaches that have the highest level of training. You can see walking behind girls, they'll be squatting in valgus with a lot of weight on their back. So again, this is something we have to correct first off. Dr. Quinn talked about CrossFit. I'm going to rag on CrossFit a little bit. This is not what we do. No, they're lighter plates, but again, yeah. So again, this is not about what we do with our training. I'm not afraid to do heavy loads with young athletes. This is a young 13-year-old girl doing a lot of weight, and she's doing more weight than those other girls. So if you train them, they can use heavy resistance, and I have no problem doing heavy resistance with her. But this is not what we do. You have to be progressive with kids. So again, you have a young girl, they have no idea what they can handle. They do a single leg hop for distance, and then they tear their ACL. That really stinks when you send a kid home from your injury prevention class and with a torn ACL. So again, you have to be progressive in nature because kids don't often know what their limitations are, and they haven't done a lot of these exercises. So that's a key aspect. But again, you can get into power training and power movements, and you have to progress to them. But the key aspect to what we do is doing that qualified instruction and giving them the techniques that we want. So just like you need for skill training for sport to improve that, we need to teach kids how to jump and land and move and master fundamental movement skills so that they can build on it. And again, instruction is a key aspect. But some of my best trainers are my athletes. Athletes that have went through the programs, they know how to give feedback. So when the athletes get to a point where they're giving peer-to-peer feedback, that's also beneficial with our training program and helps give us a larger reach when we're out on the field working with athletes. We have to include a lot of variety of movements. There's not one set of exercises that's going to be perfect for you. So you'll never see me hand out a protocol. That the athlete tells you what they need to be trained. So we target deficits with our training and look at the techniques that they need to, it's most glaring weakness. But again, we will use resistance training and power movements. If the kids are going to be playing sport, they need to be doing these exercises to make them safer. But as I mentioned, can you guys visually see that that's a high-risk athlete? So we want to target this type of athlete. And this is some data that verifies what I'm talking about as far as feedback. This is a latest meta-analysis we just published in AJSM. And basically there's 14 studies in the literature that have looked at preventing ACL injuries in female athletes. And basically, if you've ever seen a meta-analysis, if it's on this side of the one line, that means that there's a positive effect of it. So overall, there's a global effect of injury prevention. And then you see these three over here. They weren't effective. So does anybody know this study or what was wrong with those three studies? Was there anything that they did different from the rest of them? They had some neuromuscular components to it as far as design. This one printed out a manual and sent it home with kids and told them to do it at home. You think that was effective? This one, they had an instructor demo the exercises. So they showed them the movement, and then just had the kids do it. They didn't give them any feedback. They just showed them what they were supposed to do. This one had them give feedback, but they had the kids give it, and the kids weren't trained. So they just said, you guys need to tell each other what to do, and they didn't know what they were supposed to do. So all these others had qualified instruction and instructors looking at the training and giving feedback. So I think that's a key aspect to why these are effective. So here's another question for you. Who do you think's at higher risk for an ACL injury? Is it your best athlete, your stud athlete, or is it that kind of lower level athlete on a given team? Who do you think's the highest risk for an ACL? High level? Does anyone think it's lower level? Does anyone know who this athlete is right here? I'll show you a video of it. It's Cynthia Barbosa, and I was meeting with Hugh McCutcheon, who's the Olympic team coach. He came and talked about his training program and wanted to learn about getting his mechanics and updating some of the training program. And he talked about, he was really into it, this one athlete that was doing a lot of the things that we talked about. I said, well, Cynthia Barbosa is one of my athletes that I feature on tearing her ACL. Look at all the mechanics she has. Valgus landing, again, loss of trunk control, lands a single leg. You think she's a very good player? She tried out for Olympics when she was 17 in high school still. So she's a pretty elite athlete, has those mechanics. What about this athlete? Same thing. So I don't think it's necessarily the level of the athlete, it's the risk factors, and you have to focus on it. When you see these deficits, you're going to have to hit that. So again, if I answer the question, when should we start? What we have with this data now is that, again, we have those 14 studies. Maybe we can look at age effects and see if it works better when they're younger. So what we did is we broke that data apart and grouped it by early adults, late teens, and mid-teens. And the only group that was driving these positive effects was the younger athletes. So it wasn't really effective in the older athletes. This is 20-year-old adults. This is the 18 to 20-year-olds. Only group that adapted and reduced injury was those younger kids.
Younger kids, what age?
Mid-teens. So I don't have data younger than teens, but that was the mid-teens, 14 to 18. So it makes sense. When would you want to try to change mechanics on somebody? Would you want to wait till they've been very successful for 20 years and say, hey, you got some mechanical problems. Is this when we should start? That's when injury risk peaks, and that's when a lot of people implement these programs. It doesn't make any sense. I'd rather train when the neuroplasticity is high. These kids can adapt to what we're trying to teach, and then they can go through those adolescent years with mechanics that will be safer and supportive, but we need to continue these programs as they grow. So you're asking me, how early can we start? Well, this is some data Avery Feigenbaum has worked on in New Jersey, where he looked at training kids, 7-year-old kids, and adding 12 minutes to PE class. So that period when the kids are screwing around, running around, he gets them organized and did 12 minutes before PE class started. What he found is he had huge gains compared to control in their fitness and strength measures. He had huge gains in this data set. But when we looked at it, guess who was most responsive to this? The young girls. The girls drove our data. They're the ones that adapted by far the most. So they adapted to a lower level stimulus and had huge gains in our study. So that was a really unique finding in our study. So the question, when should we start? Well, here's kind of what we think and how it should work. A young child is going to have an adult neuromuscular performance potential. As they go through maturation, they're naturally going to adapt, and you're going to see that. What we're proposing, if you do training that we're proposing, hit it before puberty, you can push that profile even higher. So you can expand the window. You can create a window for a neuromuscular spurt for young females. But what I want you to think, if we start even younger, in pre-adolescence, we can even take that profile even higher. But what do you think the problem is and why we're seeing more injuries? This is what most neuromuscular profiles are getting at. I think kids are less active. They sit on their butts for 6 months, and now it's time for soccer practice, and they go, and they don't have preparatory conditioning, so now they go out and get injured. And that's why we often see higher injury rates at the very first few weeks of the season. So again, I think this is a type of a boost. It's not going to be the perfect solution, but we can implement these types of training activities to actually help young kids capitalize on a lot of things that happen during adolescence. And again, there's a lot of hormonal things that come together at adolescence. And if we start younger, we can be training these young kids at higher levels when they do get to these stages. Again, they're going to have higher levels of threshold if we start young. So when do you think it's too early to start? Is it too young? Just too young to get this kid doing strength training? All you got to do is put his toys on the wall. Keep going. This kid's 11 months. I gave this talk in San Diego, and one of the physicians sent me a picture of their kid. This kid's 11 months. They're doing the same thing, 11 months old. It's actually April Mancuso's nephew. What about this? Is it too early to start? What if we made kids do pull-ups while they're trying to watch cartoons? Here comes the dog. So I've given you just a brief 30-minute bout of training on how to identify risk factors. Can anyone pick out the high-risk athlete on this image? Coach sent me this after my talk, 3 ACLs when she got older. So this is the type of athlete that I want to identify and get them involved in training before they go out and continue to play, because they're going to go on to this. Those mechanics are going to put her at high risk. And again, it doesn't take much to identify those risk factors. So are we able to change the outcome? Does training work? This is a young girl, had an ACL. I don't know why the doctor casted her, but that's what they did. We're not going to talk about that. But the dad came to us and he said, I don't ever want to go through this again, and got her involved in a training program. So this is Jensen Brent, who does a lot of our training with our athletes at the hospital. And again, she went on through her high school years, didn't miss any games. She had some minor injuries, but didn't miss any games or practice with injury. And she trained both from her prepubertal years all through adolescence. Here she was after scoring the state championship goal, and then she was a state Ohio Player of the Year and an All-American. So again, these things that we do is not only preventing injury, because keeping them on the field is going to improve their performance, but we're also making better athletes and safer athletes. So I think there's a lot of value in what we're doing. What about RG3? Do you guys see this injury? So do you think that we could have helped the Redskins out and predicted this? What do you think? Here he is in Indianapolis at his combines. Vertical jump, broad jump.
They didn't squat that?
Must not have. And he was already an ACL injury. So again, he's already had one ACL injury, so he's probably 100 times higher risk. These are the things that we think they should have been addressing, and that's something you want to pick out. That's about a $100 million mistake. So when do you think we should start? I think the time is, and again, I didn't go through these other variables, but I think it's time to start now, whatever the age is. If they're going to be involved in sports, they need to be doing these preparatory conditioning protocols and getting involved in this. If they're going to do it, then we can get them involved. And again, the key aspect to what we do is implementing early, because when our physicians get involved, they just add insult to injury. We're going to keep our medical team on the sideline. This is my favorite. This one turns out bad. So I want to acknowledge my funding sources. Again, we're also funded by the National Institutes of Health and NFL charities. And what I really want to acknowledge is our Biodynamics Center team. This is not my work. We have a huge staff that keeps these studies going. And I'm the one that gets to come out here and show it to you guys. And our staff that does all the work.